The world is shifting. Inspiration is everywhere. We learn about the best in ourselves from each other. I'm Will McPherson, and you've hit rock bottom. Building your health and happiness from the ground on up.
On today's episode, we're going to talk about your general health and the role kidneys play in that. And we'd like to welcome Dr. Paul Dreyer, one of the top nephrologists of the world, from Nephrology Associates of Central Florida in Orlando. Welcome, Dr. Paul.
Hey, Will, thanks for having me. Pleasure to be here.
All right. You know, Dr. Paul, you spent years studying human anatomy. And why did you choose the kidneys as your focal point of expertise?
Well, probably a few reasons. One is I like kidney physiology, and nephrologists typically have to be good internists to be good nephrologists. So a lot of the subspecialists, when they get into their discipline, cardiology or gastroenterology, they'll kind of forget their medicine, but we actually use ours every day. So that appealed to me. We take care of a broad range of folks, from being very sick in the ICU to chronically sick in the dialysis unit to just having high blood pressure, and we see them in the office and get their blood pressure squared away. So there's a large range. So all of that appealed to me.
It sounds like your baseline of health, right? So my podcast, right, Rock Bottom, Building Your Happiness from the Ground Up, talks about the baseline of where your community was built, right? How it's built from the ground up affects your health and happiness. It kind of sounds like what you do. I mean, are you telling us all to scrap our general practitioners and go to a nephrologist? Is that what you're telling us to do?
Not at all. No, we work in conjunction with the primary care docs.
I assume this, though, right? That when a patient comes to you for care, you take over treating everything, right? The whole body. You're kind of the main doctor once they come to your office, correct?
We used to. Things have kind of changed in the modern era. When I first started, yes. If somebody was on dialysis, if somebody had a kidney transplant, we would essentially be their primary care physician. But in the last, 20 years, 15, 20 years, it's kind of migrated where the primary care will still see them outpatient, and they'll have a hospitalist when they go in the hospital, and then we'll be consultants in all those cases. So I'm a dinosaur, and I actually prefer the old way, although your lifestyle wasn't as good because you definitely got woke up in the middle of the night a lot more frequently on call with the orders now that the hospitalists don't manage. So.
All right. Well, it sounds like we're two peas in a pod because my expertise is housing built before World War II. Right now, how it's much better than what they're churning out today. So, hey, I think everybody wants to know, right? Everyone listening to this podcast, what functions do the kidneys have? Right? There's a lot of us that go out for St. Patrick's Day, abuse our body, go out at night with friends. We go to a restaurant heavy in salt, fats, alcohol. So, I guess everybody's thinking, for health, for optimum health, what functions do your kidneys have? What do they do?
Well, so the principal function is to clean the blood. So kidneys get, about 20% of every heartbeat of blood gets perfused to the kidneys for them to clean.
That's huge. That's a huge volume.
Yes. So it's, they get a liter of blood a minute.
Oh my God. I feel like Jerry Lewis. There was this movie where Jerry Lewis is an intern, wasn't a doctor, it was like an RN, and some lady was talking about her kidneys, and Jerry Lewis was freaking out behind her. Saying, oh, it's like, my kidneys. So that's amazing. Get a liter of blood a minute, right? Is that what we're?
Yes. Yeah. For healthy kidneys.
Crazy.
And then, that goes down if they become diseased, but, so
it does come down. Okay. So you want as much blood as possible to go through there, right?
Yes. I mean, there can be so early diabetics, when they have high blood sugar, they'll actually have higher than normal blood flow. But that what we call hyperfiltration also is pathologic. And over time, it'll cause the kidneys to scar.
Wait, what's pathologic?
Pathologic just means bad.
Bad. So, okay. It's bad.
It's bad. So you don't want, because when you hyperfilter, then the pressure is higher in those little capillaries. That each kidney has roughly 1 million what we call glomeruli. These are little capillaries that filter blood to make urine. And when they're gone, they're gone. So you get 1 million at birth. And if you've, like you said, beat up your body by doing things that aren't so good for you, you'll lose those, and they don't come back.
They don't come back.
They won't regenerate. Yeah.
Unlike liver, correct? The liver kind of.
Yeah. Liver will bounce back. And then the tubules in the kidney, they'll grow back, because sometimes we'll see somebody with acute injury because the tubules were injured, but the tubules will grow back, but those glomerular capillaries don't grow back. Yeah. Once they're gone, they're gone.
All right. It looks like you're, it's kind of chicken or the egg, right? We were talking about if you have high blood pressure, then you have kidney issues. So if you have kidney issues, you have high blood pressure. I mean, what comes first? I mean, as one ages, right? Everyone's got to watch their blood pressure. Even kids today, because of the lifestyle that they lead, are on blood pressure medicine. So I guess what comes first? Is it the kidney failing, or is it blood pressure?
Probably the blood pressure most of the time. The two most common causes for people to have to eventually wind up on dialysis are diabetes and high blood pressure. But you're right, Will. Once the kidneys get damaged, then the blood pressure starts going up, and it kind of feeds on itself.
It's like a cycle almost. Yeah. So, okay. So it sounds like what we have to watch out for today is, a lot of processed foods we're eating today. People are heavier than ever today, and a lot of people are on maintenance meds, and blood pressure's going up. So, what warning signs can you have? It's not like your car, right? When you're driving around, you get this yellow light on your dashboard that says check your kidneys. Are there any warning signs that you get, or what can you do?
For the most part, no. I mean, unfortunately, it's a silent disease. I mean, that's like high blood pressure itself, right? It's one of those silent killers. In fact, for the longest time, traditional medicine didn't even know, we weren't proponents that was a cause of disease until the 60s. The reason that medicine became aware that high blood pressure was a problem was actually from the insurance industry, because they said, if your blood pressure is more than 140 over 90, then you have a higher risk of death, and you're going to pay more for your life insurance premiums. Meanwhile, the traditional medicine is like, oh, it's fine. It's just a natural, phenomenon of aging. So that's why it's called essential hypertension. There used to be taught that it was essential that your blood pressure went up as you aged to get more blood perfused to your organs. Well, it wasn't until the 60s they had a VA study, and they actually looked at patients, and the study had them get the diastolic blood pressure, the bottom number, below 110. And lo and behold, people were less likely to die when you actually treated the high blood pressure. And then they had a second follow-up study that showed the targeted 90. And that's where we get our bottom number for recommendation for a healthy adult with uncomplicated hypertension to get their diastolic blood pressure below 90. And that's like when you and I were kids then, President Nixon was in office at that time, and he started the Presidential Physical Fitness Awards. Yeah, right? So, yeah, exactly. So that's why we had that in school growing up. That was the impetus of the government to try to encourage people to stay healthy and fit. There's an Indian population, a native tribe in the Andes Mountains called the Yanomamo, and they're 10,000 feet elevation. So they have no sodium in their diet, virtually none. But in their population, there is no high blood pressure at all.
Dr. Paul, one of the things that separates you from others is when people come in and see you when they're making kidney stones, right? And that's scary. Anybody over 40 thinks, sees someone who produces kidney stones, very painful experience, right? So, what happens when they come in and see you? How do you guide them and treat them?
So my experience, typically if somebody is passing a kidney stone, they'll see a urologist, a surgical specialist if the kidney stone's more than 5 millimeters in size, it becomes less likely that the patient will be able to pass it on their own. So they'll need some kind of procedure to extract that stone. The problem is that oftentimes the patients then, they go back to their lifestyle, and then a year or two later, they're making another stone. So my role is to say, why are you continually making kidney stones? Let's look at your physiology, and then we can use diet and some simple medications so that we can adjust what these constituents are in their urine so they don't keep producing stones. So I find it very gratifying because, like you said, it's a miserable experience, and the patients are motivated because some of them come to me and they say, am I just going to do this the rest of my life?
Yeah, we both had fathers that had them, right? You could hear them screaming in the bathroom going, oh my God, so,
yes.
So it comes. So I think what separates you from the normal treatment, right, is there's treat, but there's also the looking at the cause, right? And I know I took a look at your Facebook page, and you recommended if you're making stones, dude, you better go back to forget the paleo. Go vegan as close as you can get. Is that okay?
Yeah. So the general stone diet is adequate fluid, more than 2.5 liters a day. So the
I'm drinking water right now, scared to death.
There you go. Yeah. So 500. So one of those water bottles 5 times a day, and you want to spread it out throughout the day. So I tell them one with each meal, one at bedtime. Keep one on your nightstand. And if you do that, what you want to avoid is that dark yellow urine. That's when you're going to be making a stone.
That's stone time, man. That's a warning light. That's a warning light going on your dashboard right now. Stone light. So, all right. That's
and then you want to take in low salt, like we talked about, because salt,
which is hard to do, though, right? I mean,
you got to read labels and avoid stuff that's in there, even if you're not going to salt your food.
Well, we're a going out to eat culture. When you and I grew up, we grew up in a large town, 45,000 people. Wealthy suburb outside Chicago. Well, we have maybe 4 or 5 restaurants in the entire town. Now, there's maybe 200, 300 in that town. So, we're going out to eat culture. So, I guess you got to watch it when you go out to eat too, which people aren't doing. So I guess that's why we're seeing kind of the health epidemic that we're seeing today.
Yes. And then the last 2 things, like you said, low animal protein for general stone diet. And then lastly is, it seems paradoxical, but you actually don't want to restrict the calcium in your diet. People for the longest time, we're told don't take in dairy products, etc.
Yes.
But what happens there, the thought is that, so this is from 1992 study. They studied the Framingham population in Massachusetts, where we got all the cholesterol studies from. And somebody did a stone study on them with dietary history. So normal dietary calcium is 1,200 to 1,500 milligrams a day. Mm-hmm. Once it gets below 800, then those patients paradoxically made more stones. And the thought was that they have less calcium in the diet to bind oxalate that's in the legumes and the spinach and the other things
what's bind
eat.
Oxalate? What's that?
Oxalate is an organic anion that when it's bound to calcium is relatively insoluble in water. So if you have calcium in your diet, you bind it and it goes out in your stool.
It goes out.
Have less so you're actually getting it out that way. But if not, then you're absorbing it in your bloodstream, and then you have to filter it into your urine. And then you have a whole skeleton full of calcium that's going to bind with it and make a stone potentially. So,
all right, that's good to know, because I almost started to avoid broccoli and kale and other vegetables that are high in calcium. But so this goes without, the layman's thinking is let's avoid calcium, especially if you're, males thinking, I'm full of calcium. I don't want any more. I don't want it in my arteries. But it's the exact opposite. Get a calcium rich diet, goes out. If you're calcium deficient diet, then your body stores it and fires it through the kidneys, right?
Yeah. So you want to have the goat cheese on your kale salad. Yeah.
I love goat cheese on kale salad. That really sounds good. Sounds good, my friend. So kidney failure, right? The 2 most common causes that you should avoid, which is, we were talking about, right? Diabetes and high blood pressure.
Correct.
Asymptomatic silent killers. So that makes sense, right? So you want to limit sugar. You want to limit salt, which are the two things. But unfortunately,
maintain your ideal body weight. Have gentle aerobic exercise. 4 days a week, 5 days a week. The good thing that's happened, Will, is for the longest time, the only treatment we really had for diabetic kidney disease was using classes of blood pressure medications of either ACE inhibitors or ARBs. And so, those studies came out with the ARBs in 2002, 2001. They came out the same edition of the New England Journal of Medicine. So the frustrating thing for me for the longest time was you'd see a patient with diabetes, and their diabetes was controlled to goal, and their blood pressure was controlled to goal on their ACE inhibitor, and they're still losing function. And so fortunately, what we've had within the last, recent past year or two, we now have two different classes of medicines. One is the SGL2 inhibitors. So you may have heard of Farxiga or Jardiance. And those have been shown to be kidney protective as well as heart failure protective. And with Farxiga, it's even in non-diabetics, it's kidney protective. And then the other class is what's called mineralocorticoid antagonists. So the newest agent out for diabetic kidney disease is called Kerendia. So I actually do some speaking for Kerendia because I go to the primary care doctor's offices and I tell them, look, you're going to see these patients a lot sooner than I am. And when you see them, they're going to have more preserved kidney function. So by all means, start them on these two medicines to help protect their kidneys and their heart. And they say, are you worried that we're going to put you out of business? And I said, please put me out of business. I have 15 million recurrent stone formers in the United States that I can work up. So.
All right. Yeah, that's really good advice for everyone. Okay. So we're looking at over 55, you got to look at your blood pressure, do the blood test, urine tests. And, and like I said, the good news is if the general practitioners, get the information that Dr. Paul gets to them, you won't see Dr. Paul, right? Like Dr. Paul's my friend. I want to see him as a friend. I certainly don't want to see him professionally.
Yeah, that's any patient. I tell them, you want me to sign off of your case. That's really good for you.
That's right. Don't keep coming and see me. Okay. One last thing, I guess. Can your eyes tell you what's going on with your blood pressure a little bit?
Not looking at your eyes directly, but if you have a good fundoscopic exam, in fact, that's how I got found. So I started blood pressure medicine 2 years ago. I went to see the eye doctor. I had scratched my cornea and he did a fundoscopic exam and he says, hey, doc, what's your blood pressure been running? Because you have some AV nicking and, the findings that you see when you look at the back of somebody's eye. And I said,
yeah,
I don't know. I haven't checked in a while. So I came to the office and my blood pressure was 160 over 105. And I was like, that's real. I hit the 55-year mark, like you said, Bill. That's the magic age where blood pressure tends to go up as the arteries get stiff. So I started on medication then, and my blood pressure in 3 days was down to 110 over 70. That's amazing. It's been there ever since. So
what sucks is you have to chuck your pride aside, your ego. Like I'm gonna have to go see. Get glasses. I've never had glasses. My eyesight was really good until I hit about 50, and then I had to read a lot. And just shove your pride aside. You got to do what you got to do. So that sounds good. So
sometimes you can do lifestyle modifications with weight loss and low salt diet, but I mean, right. So that was stage 2 hypertension. If it's more than 160 over 100. Yeah. Then the recommendation is actually to start medication immediately and use 2 agents. So that's why I have a combo agent that I take and it's worked like a charm.
So we talked about what the average person in average health can do to support their kidneys. Let's talk a little bit about some of the folks that maybe have to have kidney filtration or have a genetic abnormality. What can you do? So I guess let's talk about, if a couple of people you see, maybe we could help somebody listening to this podcast. A couple of people you see this have a rare disease and you do genetic marker testing. Can you tell us a little bit about that real quick?
Yeah. So a couple things. Third most common cause for patients that need dialysis in the United States is autosomal dominant polycystic kidney disease. So that means that it runs in families and
genetic. Yeah.
Yeah, if you get it, you can just get the gene from one parent and you have the disorder. And the kidneys just become large and cystic and the kidneys fail and the patients need dialysis therapy. We did not have treatment for that for forever until recently. There's a medicine out called Genarcu. And so, but depending on how large the kidneys are and the age of the patient and where their kidney function is at, the Mayo Clinic has a nomogram that would recommend treatment in certain folks that meet these criteria. And if you can keep the kidneys from getting distorted anatomy with the medication, then you can preserve kidney function. So I saw a patient just the other day, and both his mother and grandmother wound up on dialysis in their late 60s. He's in his late 40s with essentially normal kidney function, but very large kidneys. So I'm starting him on the treatment, and I'm hoping, and I told him, I said, this is not for like tomorrow or next week. This is for 20 years down the road. I'm going to be either retired or dead, and you should still be on this medication and ideally not follow the same path as the rest of your family. So that's what we're doing. That's one that we have a new treatment for that not all patients know about. And then you were mentioning the genetic things.
Didn't you, in our pre-show talk, we were talking about a woman that you found out had a rare disease that had a problem with calcium absorption?
Yes. So it was a gentleman that had a very low calcium level. So when people would see that, they would freak out and they would treat him with vitamin D and treat him with calcium supplements. Well, he had a bunch of kidney stones. And when I saw him, I was like, what is going on with you? And fortunately, I was actually studying. So I do regular studies with the American Society of Nephrology, puts out a bank of questions. So at the beginning of March, they put out a new set, and I was studying them over the weekend, and I had just seen this patient, and then I got this problem, and I said to myself, that's exactly what this patient has. It's something called autosomal dominant hypocalcemia, hypercalciuria. So he has a low calcium level in his blood, but a high calcium level in his urine because the calcium sensor has a mutation in it, and it can't sense the proper level of calcium. And so he has some symptoms when they get low, but not too many. But when you overtreat him, now he made a whole bunch of stones, and it actually caused him to lose some kidney function. So I'm in the process of trying to wean him off of those medications and use other ways to keep the calcium level controlled so he doesn't get the cramping and the other symptoms that he gets when the calcium gets too low. So yeah, that was a very interesting one.
It just goes to show you've got to manage your own health, and you got to see, the right specialist. He wouldn't have known that unless he ran into you. So,
what we advocate for patients with high blood pressure is the DASH diet, which is diet to stop hypertension. And so it's basically, a diet that's high in fruits and vegetables, high in potassium, and low in salt, low in saturated fat. And like you said, processed food. I usually tell my patients, if it didn't come from the factory, you're probably better off eating that than something that's packaged.
Dr. Paul, thanks so much for going on the show. Man, have we learned a lot today. You can catch Dr. Paul at Nephrology Associates of Central Florida in Orlando.
Hey, thanks for listening. And check out my website at william-mcpherson.com. Building your health and happiness from the ground on up.